Hi, my name is Bridget Townsend, and I'm a student at Bournemouth University, just finishing my occupational therapy degree at Bournemouth University. And I wanted to share my innovative idea, which is about reducing repeat calls to the Police 999 call centre using an occupational therapist. So let's start the show. Over the course of the year 2018-19, the Metropolitan Police received 8,655 calls from just 5 people. They were all experiencing mental health challenges. Due to their vulnerability, some people repeatedly call the police services to support them, and many of these people may not be within the community mental health system, but they need appropriate support. This proposal is for a 12-month pilot called OT Call Response Team, to deploy with the police to an identified repeat vulnerable caller with the aim to reduce repeat callers to the service, decrease costs, improve client outcomes, and free up the force for crime, and provide best practice and in line with key National Health Service principles. So let's look locally in Bournemouth area. In 2018-19, the Dorset Police call centre received 7,426 mental health flagged incidents, which is basically equivalent to one call every 70 minutes in Dorset, an annual increase of nearly 1,500. And these incidents used 30,400 patrol office hours. Intentional self-harm is an expression of personal distress, and suicide is a sign of underlying mental illness. Bournemouth has had consistently higher than average rates of suicide and self-harm since 2001. In a review of crisis of care conducted by the Care Quality Commission, only 14% of adults felt they received an appropriate response when in crisis. Vulnerable callers do not have sufficient or effective treatment to support to meet their individual needs, particularly after hours. One study shows that 30% of repeat callers who have mental health challenges are frequent users of other services. Their condition is deteriorating. They recognise they have a problem and need help. So what's the impact on other services? His Majesty's Inspectorate of Constabulary identified that police forces are not always identifying vulnerabilities correctly and are still understanding how to respond effectively. Over 80% of calls to the Police 999 number are not related to crime. There's also a reduction in services and increased costs to the public. Hospital A&E admissions are increasing, and there is an increase in waiting times for primary care and mental health services. So what do we do? So my innovative idea is to work as a co-production with an OT and the police. Police and healthcare professionals have shared values and goals of improving service we provide to the public. Co-production requires a clear identification of issues, action-orientated implementation and leadership, and these are key OT skills. It is essential for people to access the service they need, to have their most basic needs met primarily, as highlighted in the Bradley Report 5 Years On review, and to get proactive rather than reactive support, and to receive some form of ongoing drop-in support from a professional who will take an interest in their outcomes by following up on referrals. It requires cultural change and training, and OTs influence, design, plan and implement organisational change. So why an occupational therapist? We have the tools and expertise to examine challenges and uncover the underlying causes, and they're able to find solutions and set goals within teams and with individuals. We understand that people living with mental illness need to improve their social capital, self-esteem, occupational engagement, and psychoeducation. This is done using their leadership skills, facilitation of learning, professional practice, and evidence research and development skills. Using a framework, clients and occupational therapists can explore in partnership what is meaningful to the client and their ability and self-belief to take action, what support networks a client has, or how he or she spends their time. and if an inadequate environment is hindering their occupations. By identifying and understanding the barriers to well-being, the partnership can form a plan for effective recovery. Band 6 occupational therapist has an enhanced knowledge and critical understanding of OT theory and its practical application, and is able to use their leadership skills to plan action and implementation with the support of 2 Band 5s. Key to the project having positive outcomes are collaborative, effective, ongoing support to the client, with the additional support of a trusted family member or friend. Long-term interventions work better because they build up routines. Different vulnerabilities generate different levels of need, so a personalised plan is important. Ongoing weekly groups facilitated by an OT will provide clients with skills to improve their social skills, self-belief, physical health and rehabilitation. One-to-one sessions will be used to develop and maintain skills to improve occupational balance, improving their life skills in areas such as work, productivity, leisure and environment. So let's look what this looks like in actual practice. In these steps, I've used a framework recommended by Puntis et al. To provide clear evidence for later comparable reviews. In responding to a call, an occupational therapist can assess an individual's immediate challenges and risks and start to build a therapeutic relationship. Interventions need to identify the problem clearly, develop an action-orientated evidence plan for effective implementation, and motivate the vulnerable caller to change. So the first step is an OT contacts a trusted advocate for the client. Evidence shows that having a supportive friend who is interested in your progress is likely to improve outcomes and is in line with best practices. Gentle introduction to an OT and initial assessment of risks can improve clients' trust, with a follow-up visit discussed and planned for a later date and time. Self-care, productivity, leisure, interpersonal skills, feelings, past experiences, and housing situation would be assessed, such as, does the house belong to them? Is it clean and tidy? Is it in good repair? Do they feel safe in it? What are their barriers and enablers to occupational justice and balance? Creating short-term goals will help the client's volition. When we say life skills, we mean managing stress, starting healthy habits, shopping and cooking healthy meals, and creating a regular personal hygiene timetable. So let's look at the social political factors. Locally at peak times, mental health specialists already join officers on patrol to respond more effectively. These are used as a street triage for people experiencing mental illness, but it's a reactive service. There are 4 community mental health teams in the area, and I'm proposing this project is attached to the community mental health service for adults in the area, but based at a local police station. The Dorset Council Health and Wellbeing Board aims to improve health and wellbeing and reduce health inequalities in the community. The commitment by the NHS long-term plan to deliver a faster and more efficient service for people with a mental health crisis and to develop services in the community is in line with what I'm proposing here. We know that mental illness is a leading cause of disability and a cause of lost work days, and there is a commitment to continue to expand access to services for adults with common mental health problems, with a focus on those with long-term conditions. NICE guidelines state that police should be aware of how to respond if someone shows sign of a mental illness. Every year, households will receive a government income such as benefits are struggling. Inflation affects poorer families the worst. Debt and unemployment is a risk factor for mental illness. Globally, the World Health Organization is working on developing a framework that aims to advance understanding, knowledge and action on meaningful engagement in order to co-create and enhance related policies, programs and services based on evolving evidence. This project aligns with some of the United Nations Sustainable Development Goals. It aims to end the cycle of poverty, improve well-being and educate and reduce inequalities. So if we're looking at funding, these are areas where I think we could look at maybe getting some funding and support. The PCC already provides funding for projects with their OP Relentless Community Fund, and this innovation covers 4 out of the 6 PCC Dorset Police and Crime Plan priorities. So this innovation, I published a paper on it, an article on it in Policing Insight magazine, and this received a bit of negative feedback. I think one member said it looked like it was done on the back of an envelope, and to some degree it is, but the figures are taken from documentation and audits of Dorset Police Force, and it did say 30,400 patrol office hours are used on those 7,426 incident calls. So if we, the cost estimate comes from timesing those hours by the average police person's salary, and that's where we meet that figure of nearly £700,000. So if we look at measuring outcomes, reduction in the community mental health services workload and GP appointments results in a reduction in waiting times for mental health support, and the public feels safer because the police are more visible and reducing crime. Fewer police, ambulance call-outs, resulting in a decrease in the cost of running those services. Reduction in police hours responding to vulnerable callers, and reduction in repeat callers to the police service. This results in an increase in hours and resources for police to fight and prevent crime. And we also have happier clients who receive an effective service and feel supported and empowered, and who have the ability to make changes to improve their well-being and coping strategies for the future, which I think is actually really important, that they have coping strategies for the future so that they don't fall back. So if we look at opportunities, so this process is about collecting evidence to support a national rollout of the project. Key to this is collecting data and evidence throughout the project. There's also an opportunity for further expansion to examine other vulnerable callers and police and people who use the police service, such as those struggling with alcohol and drug dependency, and providing the police service themselves with mental health support for officers on duty. Police and other blue light workers are exposed to some really difficult experiences on a daily basis. And finally, providing a community hub from the station for other vulnerable adults to build trust and positive community relationships. If we look at the risks, talented and experienced leadership is required in co-production, so finding the right candidate is really important. A Band 6 OT with experience of leadership working in community mental health services would be ideal. Another risk is vulnerable caller not engaging. Here is where the advocate comes in, providing love and understanding, support and encouragement to the client, because the OT can't be there 24/7. The vulnerable caller may not wish to attend the police station groups. We would investigate some other places to visit, although as the caller has called the police for help previously, it leads me to believe that they do have some trust in the police service and the staff. And finally, removing an OT from a stretch system to pilot a new project, that could be a problem, but it does improve the system. I'm lone working, but we have a lone working policy, so that eradicates that problem. So thank you for listening, and I'm really grateful that you got to the end. If you have any questions, do email me, and I'll try and get back to you. Thanks very much. Bye-bye.